Welcome back to the Hand to Shoulder Solution, giving pain the middle finger. I'm Carl Petitto, your host. I'm an occupational therapist and a board-certified hand therapist. I specialize in rehabilitation of orthopedic conditions affecting the hand through the shoulder. Time for a short break. Okay, let's press on. I want to talk to you today about problems that are easily fixed after common wrist and hand surgeries. Firstly, I want to explain that this is not treatment or advice. This is information sharing so that you may be empowered to make decisions for yourself in accordance with your healthcare provider. I'm bringing this to you so that you can understand the fundamentals of how your body works and how to recognize what your body needs so that you can obtain what you need when you need it. In healthcare in general, the services that you obtain and the timing when you receive these services is very important for a good outcome. Typically, sooner is always better. So if you're having a problem and it's not going away, life really gets busy. Days turn into weeks, weeks turn into months very easily, and months turn into years. I have patients come in and say, "How long has this been going on?" "Oh, a couple of years." "Oh my goodness. Well, I wish I could have gotten to this when it was a couple of months." So that really makes a huge difference. Okay, so let's get to it. Let's figure a few things out. So carpal tunnel release, we spoke about that a couple of episodes ago, where the thick, heavy ligament over the carpal tunnel that forms the roof of the tunnel is released. A small incision is made to cut that ligament and remove pressure from the nerve. That's why it's called a carpal tunnel release. It releases pressure off the nerve, the median nerve, which the pressure is causing aching and numbness and tingling through the thumb, the index finger, long finger, and or half the ring finger. Now, the patient's whole life, that ligament has been connected to the little finger or the ulnar side of the wrist and also the radial side or the thumb side of the wrist as well. And that helps give the whole carpus or the whole carpal structure support. And when that's cut, occasionally, and I don't remember what percentage of patients, but it's pretty low, the patients will have what's called pillar pain. And where that ligament is connected on both sides of the wrist, those are called the pillars where that's connected. And patients will come in and say, "You know what, my numbness and tingling is gone, but I'm having pain here and here. It's weird. I'm having it on both sides." Easily fixed. I've seen people suffer with that for a while. They've tried to do some things to fix it, with such as self-massage, which we talked about at length in the earlier episodes, why no one should massage that area of their wrist. The frequent movement, we talked about that too, that it's just aggravational. It aggravates everything, doesn't let anything calm down. It keeps the pain ramped up. But this is a stability issue. So when that ligament is cut to release the pressure on the nerve, now those carpal bones that have been getting that support since day one, now they have to kind of settle down and find their way again. So the wrist columns, the wrist is divided into columns. But if we talk about the central column, and we talk about the middle finger, or the central digit, or the long finger, this whole structure, if you look at the index finger and the long finger, you see that these joints are pretty close right here. And then on the little finger side of the hand, see how that's really open? And that's one reason why, and I don't want to get off topic too much, but most people have heard of boxer's fractures, where a person will get mad and punch a wall, or punch somebody else, and then hit with the little finger side of the hand and fracture one of these bones in the back of the hand on the small finger side. That's a boxer's fracture. There isn't really much support down here. Here, in karate, we teach people to strike with the first two knuckles. And this is why. That central wrist column is very solid. It's nice and stable, and those injuries don't happen. So what I'll do with people when they're experiencing pillar pain after carpal tunnel release, I'll have them lean into their first two knuckles with their wrist flat, not bent one way or the other, but the wrist nice and flat, nice and straight, and lean right into those first two knuckles into a mattress or the couch or something soft but firm to create co-contraction. So what's co-contraction? So in order for the wrist not to buckle one way or the other, all of the muscles around the forearm that control the wrist have to contract at the same time. That's called co-contraction. And that also sends signals through the joints, through the ligaments, through the tendons, eventually to the nerves, and then up to the brain. And that's that afferent or sensory pathway that we talked about in the earlier videos, where the body gets sensation from the environment. All right. So basically, it's retraining the wrist and the muscles and everything to restabilize itself, and it takes away the pillar pain. So usually, the person would have to do that, lean into their first two knuckles for about, or even just put a pad on a desk and get the shoulder right over the first two knuckles, lean into that. I have people fold up a cloth. This happens, how many of these do I get a year? Oh, 3 or 4, but it's something that happens that people should have an awareness of. And then they lean into that for about 10 or 20 seconds and relax, and then lean into it again for 10 or 20 seconds, done. And they would do that probably twice a day initially, then maybe 3 times a day after that. Then we have other techniques to really further maximize stability if it's needed. And then even, different techniques with a dumbbell, where I would have people pump a dumbbell, tighten up and work that back and forth motion to really stimulate all of the structures that are important for gross motor coordination. And again, it's about retraining and stability. All right. So that in a nutshell is pillar pain and how I would treat that as a hand therapist. There's a lot of other, techniques that are pretty interesting, but that it typically is the most effective. Trigger finger release. So trigger finger, we talked about that earlier too, where, these tendons that connect the muscles to the fingers, they have to be held against the bone by something. So when the muscle contracts and the tendon travels through to pull the fingers down, you don't get what's called bowstring. That the tendon doesn't pull away and like a bow, a bow and arrow. So you would all get bowstringing, pulling effect, and it maintains the maximal, most optimal mechanics for leverage for the fingers to bend and to have a strong grip. What holds the tendons against the bone? It's little items called pulleys. They're little ligaments that go over the tendon. They connect to the bones, and there's several all the way up through the finger. You can see one here. This is called a cruciate pulley, and it's a X shape. And then here's another pulley right here, this blue. And then the most common area for trigger finger to occur is here in the palm. If you look at your creases in your palm, you see a transverse crease that goes across your palm, the most distal one. And that's where the big knuckle bends. If you just bend your big knuckles and you see where that is, that's the location of the A1 pulley. And that pulley, if the tendon is gliding underneath it, that's a friction point. So that friction point causes a callus to start to build up on the tendon. So that callus eventually it gets big enough to where it catches on the pulley and pops through. That's the trigger finger. If you're experiencing this and you just started experiencing it, you got to get into hand therapy right away, and we can help you avoid the need for surgery. It's easy. It's an easy fix, especially the earlier we catch it. But if it's been going on for a long time and you had an injection and you went to therapy, or you didn't get treatment, this has been occurring for a year or so, and you have the surgery is to cut that pulley. And say, well, I thought you just said you really need that pulley. It's holding the tendons against the bone. That one you don't really need that much. All right, you don't really need it. So they cut that, and then now there's nothing for the callus to get caught on. That's a sensitive area of the body, the palm. I mean, you need to be able to lay a nickel or a dime or a quarter in your palm and not look at it and feel and say, oh yeah, I know what that is. We have a lot of nerve endings in the palm. So, sometimes it can be sore after surgery, not terribly, but where people go wrong again is the frequent movement. They start rubbing it. There's a scar there. And, when the scar forms, tends to get lumpy and a little bit sensitive because it's a sensitive area of the body. There's a lot of nerve endings, so people will want to rub it. Stop frequent rubbing of that scar, and instead just put a little deep pressure for about 20 seconds, 2 or 3 times a day. That starts to flatten out. Also, sometimes I'll just fold up a little. I'll make a little bolster, and I'll make a pad with this material, or you can use anything. So I'll make a little square bolster, so at night they can put this in their palm with a piece of gel or something, a gel pad underneath, and then put a wrapping around their hand, so it'll put pressure on the gel pad, on the scar, to reorient the cells of the scar to form more flat and parallel. And see if I can bandage myself. So you put that on, and now you got some light pressure right on that scar while you're sleeping, and that just helps to mature that scar tissue, make it flatten out, and desensitize it a little bit. But again, this is not anything that you want to do on your own, because you really want the expertise of a hand therapist to look at that and use the proper technique, coach you to proper timing for this, and then tell you what to watch out for. Nothing is should be oversimplified. Another problem is stiffness. So people will want to just keep it moving, and as we were talking about previously, that only serves to increase inflammation and pain and further stiffness. So we'll instruct people into proper self range of motion to stretch the joints, stretch the tendon, which connects the muscles to the bone, and loosen that soft tissue within the palm where scar is forming. Now, I should mention, scar tissue contracts. So as scar forms, it's pulling, it's contracting. So picture this. So the scar is developing, and now what does it want to do? It wants to pull the finger down because scar tissue contracts. So what are the proper stretching techniques? How often should you do them? How firmly should you do it? Should you have any discomfort, et cetera, et cetera, et cetera? You really need the hand therapist to take a look at that. Also, intrinsic musculature between these bones, those get tight. So how do you stretch? This is stretching the extrinsics, which are extrinsic to the hand. They're in the forearm, the extrinsic muscles. The intrinsics are intrinsic to the hand. They're inside the hand. And then, what's the proper technique for stretching those? But what about the joints? Now, if a person is having trigger finger, they probably also have some beginnings of osteoarthritis, or maybe they already had long-standing osteoarthritis, but they came down with this trigger finger. They had the surgery for it. Even though it's a small surgery, guess what? The old saying is arthritis loves a party. So everybody comes to the party, gets all excited. It gets the arthritis all excited or exacerbated. So an exacerbation is just an increase in excitement. So now the arthritis is worse. All right. So now we're treating 2 things: postoperative trigger finger release surgery and osteoarthritis exacerbation. So we're treating the arthritis and we're treating the postoperative hand. So that's where the clinician with his or her experience looks at the whole picture and then does the clinical reasoning and teases out what's the best treatment for that. And then every time the patient comes in, which is about, the first few weeks, once a week, then maybe once every 10 days or something. And then, the home program gets modified. We do some different things in the clinic, like cold laser and ultrasound, traction, some specific stretching. Now, let's talk about the Quervain's tendinitis release. Now, see my tendons pop up when I pick my thumb up? These tendons right here are connected to these muscles in the forearm. So I happen to have some right here. So the people who made this model, they did a good job. They show the skin, and then underneath the skin, you can see this tendon right here. And this tendon is held down against the bone by a thick, heavy strap of ligament material that goes right over the top. And that's a friction point. It took me about a year, but I broke my wife of the habit of wearing a hairband around her wrist. And that a tight hairband around the wrist really increases the friction. So see those tendons, they're gliding up and down. So now let's choke that off and keep running those tendons underneath the hairband, right? Well, that's a big friction point, and that's going to really inflame that tendon and cause tendinitis. Itis means inflammation of the tendon. Underneath the skin, there's that thick, heavy, that strap of ligament that's holding it down so it doesn't bowstring any more than it already is. And that's a friction point. So even without the hairband, it's very common for that to really get inflamed. I was starting to get de Quervain's tendinitis or de Quervain's tenosynovitis because my scissors in the clinic that I was using to cut Velcro straps for custom splits built up a lot of goo, a lot of adhesive on the scissors. So to open the scissors was very difficult. And I was just too busy. I was just running around, and I didn't have time over a period of about a week to clean off that adhesive from between the scissors. And it was just really causing a lot of pain. And I started, even at night, I would wake up and I said, my goodness, I'm getting de Quervain's. What is causing that? And sure enough, it was an ergonomic factor of those scissors just being really, really too tight. Sometimes, even if there isn't any adhesive stuck in your scissors, you can just loosen the screw a little bit and just make the scissors a little bit looser so you don't get that. Barbers, hairstylists, using scissors all the time. That's a important consideration. All right, so what's the surgery for this? And by the way, I mentioned tenosynovitis. That sounds a lot more complicated than just tendinitis. Well, in this area, these tendons are wrapped in a sheath, and then inside the sheath is lubricating fluid. It's called a synovial sheath. So teno for tendons, sino for synovial sheath, itis meaning inflammation. So it's the inflammation of the tendon and the synovial sheath, tenosynovitis. And also that comes along with radial styloiditis. Again, itis, inflammation, the radial styloid. What's the radial styloid? The radial styloid is this bony prominence on the thumb side. If you come to the base of your thumb and then go up to your wrist, and you'll feel a big bump right here, and that's your radial styloid. And there's a little fluid-filled sac there called the bursa sac on the top, and it gets really inflamed, and the bone itself gets really inflamed, and that's radial styloiditis. That usually accompanies the de Quervain's tenosynovitis. So the surgery is to go under the skin if all other methods have failed. Surgery is to go under the skin and cut that. It's called the transverse ligament. They're going to cut that ligament that holds the tendon down against the bone and free that up a little bit. And sometimes if there's a lot of thickening of that synovial sheath that surrounds the tendon, they're going to dissect that away and just clean all that up and then just suture it back together. So, in our clinic, I start seeing those 4 or 5 days post-operative. Usually the surgery just immediately reduces the pain. So usually they don't need a splint. What I like to do is just a very loose figure of ace wrap around just to block a little bit of movement. Again, no pressure there, but just loosely wrapped for bulk. And they would wear that probably for a few days. They just start weaning themselves out of that. Typically, there's steri strips over the top. And we have people wash with soap and water. You can get right in the shower, wash your hands, wash the wound. It's covered with steri strips. Wash with soap and water, dry it off real well. If there's if it's a situation where you don't have steri strips, or if they're not needed, we have people apply a little thin film of antibiotic ointment over the wound once or twice a day, but not too much, because if it gets soggy and it starts to turn white, that's called maceration, and the tissue is actually dying because it's just too soggy. It's like a tree trying to grow in a swamp. I direct patients to, if they see the whiteness form and it gets too soggy, then just stop applying the antibiotic ointment until it dries out and then turns back to normal color. People tend to put on way too much. But anyway, so there's another reason why you really need to be seen by your hand therapist and get eyes on that at least, once a week or so, and be coached to do the right things and to not do the wrong things. We also have to restore range of motion. So we start by just doing basic wrist flexion and extension, along with the normal mechanics of the wrist and fingers. And then, so that's flexion and extension, and then side to side ulnar and radial deviation, nice and gentle, some forearm rotation, pain-free range only. And I literally explain to people, if you go down that far and it hurts when you go that far, next repetition, just don't go that far. So it might even be just very slight, what we call short arc motion, and some thumb movements, gently, nice and easy. The range of motion is always very simple. So sometimes pulling up on those tendons, even though you had the surgery, that'll be a nice light active assisted range of motion. Or sometimes I'll have people do all the work with their other hand, and they just end with a place and hold for 3 seconds and about halfway up, and then come down as far as they can, comfortably, to lengthen that area. It's specific to the patient and what they need. At the same time, we're working to reduce inflammation. And then once the scar is well formed, then I'll give them a piece of material that they can hold to grip the surface of the skin very gently, do light stretching, toward themselves, away from themselves, to the left and then to the right, kind of a plus pattern, 5 or 10 seconds each direction, a couple of times a day. And then maybe some gel sheetings, on the scar. Not a ton of stuff. Applying little vitamin E oil to the scar once or twice a day. A lot of people will just get really intense with the scar massage. Again, that's a really bony area. And why did they have the surgery? To reduce the inflammation, to take away their pain. And then, people would get on there and rub that scar. And I've seen people, go to clinics and then they'll direct the patient to rub that scar, and 3 or 4 or more times a day. But I have people just, especially when a scar is getting, sensitive, is just lay their hand on it and then just hold it gently, to get it used to taking a little bit of light pressure to desensitize it. And then just lightly stretching the scar. If scar massage is done, we do, for a period of about, 30 to 60 seconds, once or twice a day, with the vitamin E oil. And just a note about vitamin E oil, if you look at the ingredients of a bottle of what's labeled as vitamin E oil, there's safflower oil and cottonseed oil, all these oils, and a lot of times vitamin E oil is like the 4th on the list. I just had people get the gel tabs that they swallow as a supplement. It's just pure vitamin E. And then they would snip the end with the sharp scissors or poke it with a pin and just put a couple of drops and just rub it lightly for like a minute, once or twice a day on that. And that goes a long way, and that won't aggravate the inflammation. Osteoarthritis exacerbation, from the surgery, we talked about that. So now they had their surgery. Arthritis loves a party. The arthritis is now exacerbated, all excited. We want to get that calmed down. Cold running water during the day, midday and at the end of every day, only until it's deeply cold, 10 or 20 seconds. Low heat in the morning, for 10 or 15 minutes, the lowest setting on the electric heating pad. And then maybe some light stretching, but not frequent movement, not rubbing it, etc. Okay. When a scar gets sensitive, it's natural to want to protect it continuously. And all patients come in, they're wearing a glove. Sometimes the fingers are cut off the glove, so that the glove is just covering that, or they're wearing a bandage on it constantly. And what I explain to my patients is, the more you protect it, the more sensitive it's going to get. It's baby skin. It's brand new skin. And if the scar is not exposed to the world, then it's not going to get desensitized. But we also, on the other hand, we don't want to overdo it either. So if they're, wear a jacket that has a really rough sleeve, and they have to go out to the grocery store, and maybe they'll put a bandage over it to protect it when they're wearing the jacket, so the heavy sleeve is not grinding against it. But otherwise, during the day, they would not cover it and have their soft sleeve from their flannel shirt or something on it, or they're doing dishes, or they're doing other things where it's contacting things, and that helps to normalize it. Thankfully, I'm blessed. I don't have any injuries right now. If I put a glove on my hand and I keep a glove on my hand for a month and I don't take it off, when I take that glove off and I go to touch something, wow, my sensation is going to be increased. Everything's going to feel very sensitive to me. Just like if you were to put earmuffs on for several weeks and then take your earmuffs off and you're going to say, holy cow, I can really hear everything. It's too much. Or if you wear sunglasses constantly indoors and outside, now you're gonna take your sunglasses off and now you're photosensitive and now the light really affects you more than it ever did before. So same thing, we don't want to overprotect. And again, that's another reason why you just want to at least get into your hand therapist for a few visits so you're doing all the right things. Thanks a lot for listening and watching. Let's do some more videos. We'll figure out a few more things. Write some comments down there. Send in some questions so we can talk about those. I really want to know what people are thinking, what people are dealing with, and let's figure out a few more things. Thanks for watching.